Okay, so we're going to talk about what is critical appraisal and how you should properly read research articles so that you can know if the evidence is good evidence or less good quality evidence. A lot of times when we see a paper, we just skim it and we don't follow a systematic way of looking at the paper. So we're not really reading it properly. We'll talk a little bit about why we need to critically appraise our evidence and why it's important, and then spend some time on how we critically appraise an article. And we'll actually work in both as a group and in smaller groups to practice this, because it is a skill that needs practicing, and we use checklists that we'll get through in a little bit. And finally, I hope you have all brought systematic reviews, and if not, we'll pair you up with someone who has, and we'll work together to critically appraise a systematic review. But before we move forward with the content, I would like to get to know you a little better and see what you actually think about critical appraisal and what you know. So if you all can go to this on your phone or your laptop, what I've found is that if you go to pollev.com first, and then it asks you for the username is Jomana Isa H210, and then it'll ask you to put in your name. For Donna and for someone else,
I go straight into that.
you should already be there.
So what's my name?
I put in Dana. Your name is already there.
Here, you put your name or you put Jomana?
Let me move to the screen. Hold on. Okay, you should come to this screen. Let's pause. No, it's okay. Hold on, wait, don't answer until.
Do I need to put Jomana Isa?
Ik heb zo wat staan, ja. Okay, so why is it not connected, Neta? Do you know?
No, I thought you disconnected it. Maybe you go back to your. Is this what you're sharing right now?
Should be.
I think because it has.
Okay. We can't see it on the screen, but we'll look here. It's a small enough room. The first question was, in general, how do you feel when you are reading a research article?
Should we press join?
Join.
And then username?
The username is Jomana
Right.
H.
One N.
It's J.
H. To one.
Jumana ESSAH 210.
No phone.
Do you want me to do it for you? Probably easier.
Do you want us to answer?
No, answer the first question only.
Okay, in
Yeah.
general, how do you feel?
Jomana S.
No, Jomana ESSAH.
Jomana. Isa. Okay.
Are you in? Okay. So, in general, how do you feel when you are reading a research article? The options are effective. It's easy for me to understand. A bit lost. I don't know really where to start. Stressed, but I get through it. Or like someone is torturing me. So we have an equal number of a bit lost, don't really know where to start, and the torturing. So hopefully by the end of today's session, you will feel less tortured when you're having to read an article. So let's move on.
Shall we answer it?
Yeah, did you?
No.
Okay. Now, you should see a second question that says, have you ever critically appraised an article before?
That's a subjective feeling. Might be
Yeah,
that
it
I'm-
is. It's totally
I'm not
subjective.
stressed, but I'm not doing it.
Yeah. Okay, so 57% of you have critically appraised an article before. And what we actually find is that most people think they are critically appraising, but when we look at the criteria and the different elements we should be looking at, in the end, we are not, following protocol. So I'd like to ask you at the end of the session, after you've heard what we need to be doing, if you still think you have critically appraised, an article. Okay, let's move to the next question. Okay, what do you read first when you are reading a research article? Is it the introduction, the discussion, the methods, or the results?
First, yeah.
Abstract.
I did put the abstract in
You
on
need to do the
purpose.
abstract
Because, no,
Actually,
most
I-
people do
After the
read the abstract. After the abstract,
After-
what do you read?
מסקנה,
Actually, I read the result.
right?
אם
me
זה
too.
שווה להמשיך
כן.
איתו.
Okay,
אני מתחילה עם results,
גם לא.
ואחר כך
רק
חצי
result.
introduction discussion אני קופצת ביניהם.
okay.
אז methods זה
Interestingly,
האחרון.
It depends, like it's
Yeah.
which if it's a very specific study, maybe I
Uh-huh.
go straight for the results if I know what I'm looking for.
yeah,
But if it's like something new to me and I need to first to go through the background, maybe I go to the background. first.
yeah.
It's really depends.
Yeah, it really does depend. And again, a lot of this is subjective and it depends on personal preference. There's no right or wrong answer.
I
It
find the
really-
discussions sometimes put everything in a context,
Yeah,
because it says a little bit about the background,
But
and
you
then a
didn't
little bit about the
answer.
methods and the limitations and the results. So
like
it's
I read the methods first, personally. And then I look at the tables for the results. I don't read the results. I look at the tables and usually that'll give me an idea and then I know whether to continue
I try to.
or not. Okay, let's move on to question 4. Okay, this is a open question. What do you find most challenging about reading a paper? It could be something as simple as the language. It could be, the length, not knowing what to do, statistics. Language.
Like language actually.
Yeah.
Sometimes.
It also really depends when we're talking about language. If it's something in your field and you're familiar with the terms, like when I'm reading something in Hebrew, if it's directly related to lifestyle medicine or to health promotion, it's much easier for me to understand than if I'm reading something that's in Hebrew, that's clinically based that I have no idea,
Mhm.
What's going on. So it also depends on, your area of expertise. Okay, so we have detecting biases, the background, critically appraising, the language. Okay.
Yes, it's nice.
No,
Let's,
for me, like all the statistics, there are all kinds of methods, and I find I struggle with it. Like,
yeah, and hopefully,
I have the background, I studied statistics.
Yeah.
I got many talks about critical appraising,
yeah,
systematic ones, but once you don't do it, like it comes in and comes out.
it's true. It's like language. Like with statistics,
When I
we-
see it in the class, when they teach me how to critically appraise, I'm like, oh, that's easy and I can
Yeah.
do it. But then a month later, I read a paper and I can't.
and one of the points I want to get across is that you don't have to be an expert in statistics. I am not an expert in statistics. Complex statistics.
If
I
you
leave
like
it for the
huge ratio, I should
statistician.
Go back and read what it is.
Yeah,
I mean,
and because,
even like huge ratio, that every paper.
Yeah.
I have to go to read what is.
yeah, it's because we don't use it, on a day-to-day basis. So the last question, just to frame things for me, what do you hope to gain from this session?
לא הגיע.
We didn't.
I have to activate it, sorry. There you go. הסטודנטים מאוד אוהבים את זה, הפול everywhere, והקהות, כן.
Maybe systematic approach.
Good, tools, appraise better, good.
Guys.
Systematic approaching research papers. If you don't, this is a word cloud. If you're not familiar with it, we're a small group, but usually when it's a larger group, people answer the same thing over and over again. And the words that are larger are the ones that are most prevalent. Yeah. So
what's the biggest appraisal?
tools, systematic, and appraisal. Okay, good. So that kind of gave me an idea of where things stand with
I also
you.
want to understand it. How do you say it?
And even
I want to understand it deeply, so I can, when I analyze the paper with my physicians and nurses in our journal class, I want to be able to get it through them too.
yeah,
I find that sometimes I understand stuff myself, but when we do a journal club and I try to show them the limitations of the paper, what's the strength of the evidence, I'm not as didactic as I'm in other stuff. Like
Yeah.
if you want to ask me about the protocol of head injury, I don't need anything. I can talk to them and I can show them the evidence of that.
mhm,
But when I read a new paper and I want to understand what's the limitation, how do we use it clinically, knowing what the limitations are, I find it very difficult to do.
sure.
So, לא עובדים עליי, אני אומרת, יש נושא שאני לומדת, לא, אני אומרת, אין לי מספיק ידע, ייקח משהו שיש לי ידע בו, ואני חיה אותו, אז אני יכולה להעביר את זה לצוות שלי, תראו, אתם רואים ילד ככה, מזה תדאגו, אוקיי? מזה תדאגו. זה דבר שצריך להגיד.
No, it's recording the general
לא, זה
screen.
קשור, קליניקה אני עושה, אבל מאמרים, כשאני מנסה להגיד להם, תראו, אלה המגבלות של המאמר, אני לא מספיק מבינה את זה, אני לא מספיק חיה את זה, בשביל להעביר להם את זה הלאה. אוקיי? זה נשאר ברמה של סיסמות, לא רק המגבלות, בכלל להבין את המאמר, לפי מה עשו אותו, מה המשמעות של התוצאות האלה, מה החוזק, מה החוזק של המאמר.
החלק הזה של להגיד המאמר ענה על שאלה מסוימת ועשו ככה וככה,
זה כן, אבל מה החוזק שלהם?
Okay, let's continue and we'll have some time for discussion later. Because it's important for us to actually get to the practice part, which is, the most important. So before we talk about what critical appraisal is, let's start with what it's not. It's not just negatively dismissing a piece of research because, you think it's not good. We cannot do that. It's not looking at only the results. You have to look at the entire article, the entire process. It's not, this is what Donna said, it's not based entirely on detailed statistical analysis. And this is a point where a lot of people get stuck. They see the complex statistics and they just put the article aside, they become overwhelmed and they don't continue. And it's a real barrier sometimes when you're trying to understand articles and do research to feel this way. So, it's normal to feel threatened by or afraid of statistics, but even if you are, you can still critically appraise an article properly.
Mhm.
And finally, a lot of people think that critical appraisal is only for researchers, but it's not. It's not only for expert researchers. What critical appraisal is a balance and assessing both the strengths and the weaknesses. And even though we do use a checklist that's very systematic, at the end of the day, a lot of times your decision regarding the evidence is subjective, because you have to look at it in terms of your specific situation and your specific case. So you do really need to weigh the strengths against the weaknesses. Like we said before, it is an assessment of both the research process. We're looking at the process that was done by the researchers and the results. And something that a lot of times as clinicians, particularly, that we might not remember is that there's also research that is qualitative in nature, where we do a lot in health promotion, where there's focus groups, where there's interviews, and the analysis of qualitative methods is just as important as quantitative methods. And usually when you combine the two together, that's when you strengthen, the research. So for example, I'll bring the case of home visits, the research that we did with Dana, home visits after a child injury, and to see if actually home visits are an effective intervention to reduce coming back to the hospital because of an injury at home. There's the whole quantitative aspect where you look at numbers of hospital admissions, the statistics, but also there's, when we're looking at particularly the effectiveness of an evaluation of an intervention, it's important to also talk to the parents, to interview the parents, to bring parents together in a focus group and understand what worked well, what didn't. So please also remember the importance of the qualitative side in addition to the quantitative. And something that's important is that all health professionals, all clinicians, need to know how to critically appraise. It's not just the job of researchers. Even when a patient comes to you for advice or seeking treatment, and if it's something that's new, it's your job as doctors to go back to the evidence, to go back to the literature and, see what's been done, see what the results are, and determine if it's good evidence for your patient or not. So formally, the definition of critical appraisal is assessment of evidence by systematically reviewing its trustworthiness, its value, and its relevance. So the whole relevance part is very critical. This is a very essential skill that you need when you're doing evidence-based medicine.
Again,
Trust, value, and relevance.
So I understand trustworthiness
Yeah,
and I understand relevance, but value sounds kind of vague.
right.
yeah, we'll talk about it in a second. It's the value of the results, actually, and how valid the results are and how it's presented. Okay?
מהימנות, תקפות.
כמו העקרונות של ארגון פשע.
Okay.
Yeah.
Family.
So this is a slide. I don't know if you've seen it before, but there's 5 steps when you're doing evidence-based medicine. You've already done the first step. You talked about creating an answerable question. If you remember, Michael talked about PICOs.
Yes.
And how to, properly write your question, particularly when you're, that's important, to assess when you're searching. The second step was last week when Nenta talked about how to actually search the literature to find the evidence. And hopefully you've done these 2 steps by now. The third step, which is the focus of today, is critically appraising. We're going to look at the evidence, look at its validity, its impact, how applicable it is. The next step, which you'll do in upcoming weeks, is to integrate the evidence with actually the practical knowledge that exists and also take into account the patient preferences. And finally, you want to evaluate the effectiveness and the efficiency of process and put any lessons learned into practice. So that's the cycle that you should always keep in your mind when you're thinking about evidence-based medicine and how to do evidence-based medicine. So it's probably obvious by now why critically appraising articles is important, but just to make sure that it's clear, first of all, it's important for you to recognize that not all studies that are published are good quality. there's a big difference between quality and different studies. And just because it's published, it doesn't mean that you should automatically, trust everything that's written in the paper. It's your job as reviewers, as clinicians, to be able to systematically review what's written and then take the paper, take the evidence and say, this is good evidence, it works for me, or it's a bit weaker and maybe I won't rely on it. Also, another reason we critically appraise is to identify the most relevant papers. I don't know if you have done, you've all started with your literature review. I don't know what databases you're using to look for evidence, but I'm doing a systematic review now with Professor Edelstein on the enablers and barriers of vaccination in the Arab community. It's a systematic review. When I went to the databases to search, I got something like 15,000 articles. So of course you limit and you put different limitations to narrow down your search, but also what critical appraisal does is it helps you identify the most relevant papers, because it's not realistic for you to look at so many papers. You need to narrow it down. Obviously, it helps you distinguish opinion, assumptions, and misreporting and belief. It lets you assess the validity of the study according to specific criteria that we'll talk about, its usefulness and its clinical applicability. And you always need to keep bias in your head. You're looking, if things are biased. And also it helps you because today patients come to you, not all of them, of course, but some of them come to you with different treatments that they've heard about, or they've, looked on Google. We call it Professor Google now, and they've done a quick search and they found they found something, a newspaper article that says drinking coffee will kill or something. So they come to you with all of this, these ideas, and it's your job as a professional to actually, know the evidence and find it so that you can show them, what's true and what's not so true. And obviously not all patients are the same. And, I stress this again and again, but one of the main reasons that we critically appraise is to see if the evidence there is relevant to our patient. It might be a study that has excellent results, that's very valid, that, it was done in a very systematic way. Everything is very, good quality. But when you bring it, to your specific case, for some reason it doesn't work. You can't.
We know today
Yeah.
that most of the research is not done on patients.
Of course.
Because everyone is different.
Of course. So you've seen the slide before, but I just wanted to bring it up again to show that there are different levels of evidence, and hopefully you should recognize that systematic reviews with meta-analysis are the top level. They're the strongest. And usually when we do critically appraise, we look at the top 4 or 5 layers in the triangle. Okay.
Maybe sometimes core studies like observational studies be more strong and reliable than RCTs. It's done well.
If it's done well, it's good evidence. It doesn't mean that it's not strong, but usually randomized control studies, because they are done in a systematic manner, and you're comparing a group that receives the intervention with a group that receives the control, they're considered the best type. But it's not always, we know this, especially in public health or health promotion, it's not always feasible to do an RCT. So you shouldn't, because an article that's an observational study was done, you shouldn't rule that out and say it's not good.
Yeah.
it can be just as good because
can have
you
an
can't,
Observational
yeah.
study with 20,000 patients and an RCT with 40 patients.
Yeah.
It doesn't mean that RCT is strong.
I just want to talk about the point that RCT is taking patients in not a real world. It's a trial. It's at like, but in the real world, you take into consideration that maybe patient didn't have a car to come to the hospital. This is the
course.
real world. So if you, I heard once that if you're taking a course like observational study that's
it's
done
good
well,
quality.
it's going to be like
It's just as good,
Yeah,
yeah,
yeah.
it can be just as good. Don't just look at an article and if it's not an RCT, say, oh, it's not good quality, because again, when we have to apply things to the real world, like you said, it doesn't always work. Sometimes we can't do RCTs, so that's not, a factor, but
It really depends on your
Yeah.
topic. If you want to compare two different types of treatment, then the RCTs will give you a good measure of efficacy.
Yeah.
But
Mhm.
there's also something called effectiveness in real life
Yeah.
conditions.
Yeah.
And that has to be observation. But yeah, it depends.
okay, so we're actually gonna get now talk about the how. A lot of times people, they fear critical appraisal, and we have this picture of a bear who's like, no, not me, I don't want to do it. But hopefully we'll simplify things and we'll make it, so that it's more understandable, more clear, and less of a concern. So how do we do this? First of all, we are very lucky that we have critical appraisal checklists that have been studied, they've been evaluated, and they've been validated by other researchers. So there are tools out there. We don't expect you to reinvent the wheel and come up with your own tool. There are enough tools out there that do that evaluate in a good systematic way that you can use, and they are very helpful. The one I like to use and the ones that we'll use today are actually the critical appraisal skills program tools. But just so you know, there are over 120 different types of checklists or critical appraisal tools, excuse me, and each tool that you use, there's not one standard tool. It depends on your research or study design. So today we're going to look at critically appraising an RCT, a randomized control trial, and then we're also going to look at the tool that critically appraises a systematic review. Okay. So I just put this in here.
And
So
how can we find if we want to?
if you type the name of the tool, if you
How
type,
can I find from all these tools, the tool that is best for the kind of paper that I'm reading right now?
well, if you look at the primary quantitative research design. So this would be like RCTs or
Where does it say the name of the tool?
this is the name of the
That's for
tool.
specific experimental
Yeah,
studies,
so this
specific
is for
case studies.
experimental studies. This
Okay.
is for observational studies, and all of these have been, validated, and they're all good tools to use. The ones that I like the best are the CASP, which is the critical appraisal.
Yeah, it goes in
program.
many kind of.
Yeah, and also the JAMA evidence is a good one. Okay,
Mhm.
so I just wanted to show you that there are a lot out there. So in general, we're going to start in general, and then we're going to go more specific. There are three broad issues that we always want to consider when we are appraising a research article, regardless of the type of design. We always want to look at three things. First, are the results of the study valid? We want to know what the results are and how they're presented. And like we said before, how can I apply the results to my patient care?
So you actually say we were right reading results first, not methods.
Right,
No.
Yeah,
yeah, you want
But
It's
to
you
know.
wanna
important.
say-
I like-
You want to answer the first question, you need to know the methods. Are they valid or not? You
No,
need to know
but
the
the
methods.
question, the first answer she wrote is results.
yeah, it's really a matter of preference. If you read the results,
Validity,
yeah.
you're right. The whole about validity depends on the methods.
yeah. Okay, so there's two types of validity.
That's right.
there's two types of validity that we look at, in general. And validity is really how rigor or how sound the research was done. In terms of external validity, here we're looking at how generalizable the article that you found is to your own population. Is the sample similar? Like if you're looking at a study on, I don't know, diabetes interventions, you found this wonderful RCT that looks at African American patients in the US, but your population is the Arab community here in Israel. You need to know how much you can really make it generalizable to your own population. Just because it's looking, at the same thing, we know this. It can't be, it has to be culturally appropriate. It has to be sensitive. It has to be adapted so that it can work on your own population. You need to look at who was studied. Are there important patient types that were excluded from the research? If you're focusing on adults and the study is done on children, obviously, you can't validate using this evidence for your own work. Sometimes gender can play an important factor. If you're looking
Most
at,
of the time.
yeah,
Now we know that most of the time.
that's true. Men versus,
Research is not done on women because of the menstrual cycle.
Yeah.
So research is not basic sciences and not clinical research are not done. When I did research in Berkeley, they always use male mouse. They never use female because you have all the menstrual cycle that ruins everything. When you study hormones, when you study efficacy of treatment. So the menstrual cycle interferes with that.
now it doesn't mean,
Is done on men.
it doesn't
Much
mean that if you
simpler.
find an article that was done just on males that you throw it aside and say it's not good. You just need to be aware that, you need to make adaptations and make sure that, that is a limitation that when you're using this evidence that you need to take into consideration. The applicability of your evidence to to your own context. Again, you might have found this perfect article that is valid, it has great results. But for example, it's testing the use of new equipment to do something. When you bring it back to your own case, first, do you have the money to buy such an equipment? That's an important, consideration. Second, you need to train people how to use this equipment. Do you have staff? Do you have funding to be able to do the training? Can you really afford it? So all of these are concerns that we need to, to be aware of when we're looking at the evidence that we have. In addition to the external validity, it's important to consider the internal validity. And this is the actual validity of the results or the way the study was done. Are there clear statements of the aims in the research? Is the design clear? Is the population, clearly defined? Is there an intervention that's defined? A lot of times you might see, we did X intervention among this population, but when you read further, there might not be enough details about the intervention itself. How many times was it done? What exactly was done? What were the details of this, workshop or this treatment? So that's really a concern for you when you're measuring the type of, the amount of validity of an article. Were appropriate methods used? For example, we know, Nantha just said, if we're trying to test, whether a specific drug is, effective or not effective, then the randomized controlled trial is the best type. But if we're looking at a specific intervention, an observational study or some other type of study might be more appropriate. So you really need to look and see if the researchers who have done the study, if they actually use the most appropriate methods. And again, the relevance of participants and the selection, how your participants were selected.
One of my problems in critically appraising is that I can understand what you're saying now, but I feel I don't have enough knowledge of all the kinds of papers of research that exist. And if I have to see if they use appropriate methods, then I don't have the basis for that.
Okay,
Because I
hopefully,
don't know what kind of research exists and
Yeah.
what is best for everything. So I get into like this vicious cycle. I want to see if it's valid, but I don't have enough basic knowledge. And maybe it comes with time, I guess.
it does. It's a
time.
skill that you
But
develop.
that's what you're talking now, and you say, okay, I want to do that. I want to go through the checklist, but I have a lot of stuff missing that I think people who deal with the research, that's their language.
Yeah.
I see my husband, that's how he thinks about everything because that's how he was raised. I wasn't raised like that. So I have to go over those checklists without a background.
Mhm.
I feel like
Yeah, it's a
I'm walking on
challenge. I
unstable
think
What
with,
does it do?
So you need to,
critical appraisal.
hopefully this part will give you some idea.
yeah, I
Okay.
think next session, I think in the next session you talk about study designs and the types of designs.
I'm just sharing.
And yeah, no, it's,
saying we didn't grow up like that. We never learned it. We never, so I think like
That's why you're
for
on
me,
this course.
yeah,
נכון,
If you study in
זה
the
הולך לנו קדימה ואחורה, נטע. זה כאילו קדימה ואחורה. זה חלק מהקושי שלפעמים אנשים שמתעסקים במחקר, יש הקושי הזה, כמו שלי ברור, שאני מסתכלת לי על חולה, אני יכולה לתת לך צ'קליסט שתגידי אם הוא חולה או לא חולה, ואת תגידי לי בסדר, אבל אני לא ראיתי מספיק חולים, ואני רואה ואני אומרת, הוא לא נראה טוב, כאילו, כי אני ראיתי. אז אותו דבר, this thing, בשבילי זה כאילו סיני, אני מבינה את מה אני צריכה לעשות, אבל אני לא ראיתי מספיק או עשיתי מספיק, ומה שקורה because of that, we are not doing it enough, and then we hear these talks and we don't do it. So how do we keep on, that's what I'm asking myself.
it's a challenge. I
do we-
think you need
How do
to,
we take that? Because I have a lot of holes now in my head.
Yeah. I think, when you see the checklists and you have those tools available, they'll help guide you. And it's important to know that when you're critically appraising, it doesn't have to, even if there's one part that you're not so sure about, it's not gonna, really impact the quality of the article unless it's something major. But, you should know that at least the author recognizes the limitations, and that does make it, a decent study. And I think with practice,
I feel I needed a course from all the parts of the research, like the first part that we did with Michael, or the second part we did. I thought, okay, I can deal with it. But the part of critically appraising, I feel like, for me, I don't know, I feel like I need a whole course just about that and just analyze papers after papers to get trained and to get it into my system, because that's what gets.
I agree. A 3-hour session is not enough to give
We
you,
have to do it ourselves.
Yeah.
Yes. I
Yeah.
don't know.
but hopefully, you'll be aware of the tools that you have
Yeah,
available.
okay, no, that's a
And
good
that can
step.
help you. Okay, so the next part, we talked about the validity. The next part is the results. The results really need to be clearly defined, clearly stated. What were the findings? Are they justified? Are the results precise? And this again is very general because we'll focus more when we talk about the specific research designs. And finally, this is repetitive, but the value and the relevance to your own situation. Can they be applied to your own research? You have to look at the benefits. You have to look at the harms. A lot of times you might find a study that looks at the effectiveness of a drug and that it is, effective at reducing symptoms or at treating a specific disease. But when you look on the other side at the side effects, are the side effects really worth, the,
It's like sitting
yeah.
and having to.
yeah, exactly. So you have to consider it. I mean, there's no right or wrong
Sometimes you have to
answer.
choose a cutoff point.
Yeah.
You say some kids I'm not gonna identify as having cerebral hemorrhage post-trauma, but I'm gonna miss like 0.01, but in order not to do CT to everybody.
Yeah,
Like you have to.
Number needed to check.
yeah.
Right.
And that's
So you
something,
need to decide on the cutoff. It's
Yeah.
not just black or white. Just you decide where you want to be on this
Of
scale.
course, of course. And each patient is unique. You need to take into account their own circumstances.
Mhm.
Okay. So I think we should take a break now. Because my next section is long.
Okay.
Um,
Okay, let me check if they can go. Well, why don't you pause the
Recording.
And then I'm gonna check if
אני אומרת לך, אריאל יכול להיות לו חתן, הוא ילמד את הנושא, הוא יפתח, הוא יקרא מאמרים.
כן,
עכשיו אנחנו מבקשים, יאללה,
נכון, נכון.
אין פה כלום. כאילו זה עניין של צורת חשיבה.
Okay,
Okay,
let's continue.
you should have an article that I handed out on saline. And you should have,
ניקח את הארטיקל הזה עכשיו?
Why do I have all
This article, look,
קדימה.
לא, אבל למה יש לי את כל העותקים?
את צריכה לתת כן. יש לך
we're gonna talk about this article now.
אוקיי.
תסתכלו רגע, שיהיו בארטיקל הנכון.
היפרוטוניק סלן.
מה שאתה רוצה כזה?
מה? יש לי, אבל זה של חמודי.
או, מעולה, זה בשבילי.
חמודי.
I don't have a copy.
שלא עוזר היפרטוניק סלן.
זה שלך?
זה לא עוזר.
Thanks. Okay, so I brought an RCT and you also have the CASP checklist. This is specific for, if you see here, for randomized control trials. It's very important that when you're printing out checklists to use, to make sure they're appropriate for the study that you're looking at. Because, for example, here, they all look the same, but this one is for a systematic review. And the questions are very different.
How do I know I have to go to methods and see that it's randomized control? So
Yeah.
You have to go to methods.
First, you have to find the article and you have to see what type of study it is. Usually in the abstract. A lot of times it's in the title. Okay. So let's take a step back first though, and look at our case.
What do you see first of all? What do you see that's RCT?
If you look in methods in the abstract,
Okay.
it says randomized control. Yeah, double blind study.
כבר למדת את הקורס הזה.
Yeah. Okay. So when we have, I'm repeating, when we have our checklist, you need to make sure that the checklist is appropriate for the article design that you have, for the study design. In this article, the question was, how do we know what the design is? If you look in the abstract, it should always be written in the methods. So if we look in the methods, it says randomized.
So we can go to see it's randomized control and then go to the slide you showed.
And then go to the
and look
checklist.
which kind of checklist
Yeah,
should we use for this kind of study.
exactly. So, but taking a step back, before we do all this, usually we have a patient that comes in, right? We have a case. And that's why we want, the evidence. There's something going on here. Okay. So this is our case. If you look at the screen. So if you'll read the case in Hebrew, if one of you will read it for me.
אתה רופא במחלקת ילדים. אימא לילד בן 4 שמשתעל מאוד.
לוחצת לתת לילד שלה אינהלציה ממלח.
והרופא מסביר לה שזוהי התערבות שלא הוכחה כמועילה. חיפשת ומצאת מאמר הקשור לנושא הזה. ומועיל לאמא לדעת שהיא נותנת משהו.
Okay.
וגם מופיע.
אוקיי.
We know.
בטראומה. נורא רצתה לתת לילדה נוזלים, אמרתי לה, איך צריך?
Okay.
אז בואו נסתכל על המאמר.
Let's look at I've done the work for you and I found the article, okay? But if you think about the process of evidence-based medicine, what you probably should start with is your PICO. You ask the question and then you do the search of the database. And this is one of the articles that you have found, okay? So I've done all of that work for you. But let's just to review, let's go over what is the PICO for
it's a child.
preschool child. It's good to always be specific. What is the intervention?
Hypertonic
hypertonic
saline
saline
for wheezing.
inhaled hypertonic saline.
Okay, and what is the comparison or the control?
Children that didn't get hypertonic saline.
Okay, and the outcome, what are we
Let me
looking
see if
for?
there's improvement in the symptoms.
Which are?
Wheezing.
Coughing,
Wheezing,
Number-
coughing.
Number of
No, you can decide. For instance, there were a lot of works about Chinese medicine and asthma. So there is improvement in the child's feeling. So the outcome, if you look at the outcome, how does the
But
child
she's
feel?
asking about the
About this
outcomes of this
article.
In this
Yeah.
outcome?
What
But
are
you have to
the,
ask yourself which outcome you're looking at. No.
no, the outcomes, let's do this
When you
article.
choose the paper, you have to choose the outcome that you want. Because if you want to see a subjective improvement,
Yeah.
Chinese
case.
medicine is good for, but if you're looking at lung functions,
respiratory
then
rates, saturation.
Chinese medicine doesn't help at all. And then you have to clearly define the outcome that you're looking for. in
Okay,
the
according
papers,
to our
because
case,
it's not even
what's the outcome here?
the outcome here.
Acute wheezing.
It's not defined here.
It's not
What
defined.
is
It's not
useful?
defined.
Useful is symptomatic relief. Useful is lung function that goes better. Outcome is releasing early from the ER. Outcome is not coming back to the ER after you released it. You can have useful can be a lot of things here.
Yes,
Yeah,
okay,
but-
so,
So I know these papers.
Yeah.
That's what I'm saying. A lot of papers that come from the States, useful is release early from the ER because they care about
money, yeah.
they want the child out of the ER as soon as possible. So
Okay.
if the child feels well and goes back to his
Mhm.
physician, that's useful.
So as a
In Israel,
pediatrician,
it's not useful because we don't care
Yeah.
to keep them longer.
as a pediatrician, looking at the clinical side, what would be your outcome that you want to?
Okay, first of all, I don't know
It's
what
all-
this child has because coughing is a big DD. Okay, so coughing is a big DD. But let's say bronchiolitis, that's what so I want a lower hospitalization rate. I want to have back to feeding as early as possible. And I want him out of the ER
Saturation, maybe?
soon. Hmm?
Saturation.
Saturation,
like-
yeah, a work of breathing. You can define what useful is. Here about
What's
with this
useful for the
vignette,
mother?
for the mother, she
Yeah.
wants the child to feel well.
To feel well and to stop
And she wants
coughing,
it to be
right?
safe.
Yeah.
I think as a physician for the mother, you don't want to mask a dangerous situation. So if the child feels well and the mother feels well, but he goes home with his lungs that are not functioning well, for me as a physician, that's not useful because I put him in danger. And that's something I have to transfer to the mother. So I think you have to really define what the outcome you're looking for, and that's how you should talk to the parents.
Okay, exactly. That's a good point.
Because you can mask
Yeah,
stuff.
of course.
We can, with medicine, we
Maybe-
can mask a lot of dangerous.
But maybe on the other hand, that everything that's gives like make that child feel better, you can use it because inhaled hypertonic saline don't have any.
It has.
adverse
Children
effects.
got hypernatremia.
Yeah.
You can have any medicine, you can,
Inhaling.
Inhale, separately.
more with babies, not 4 years old.
Uh-huh.
So
You can-
we don't need to go into the
Yeah.
specifics.
Okay.
I'm just
Okay.
saying that this
Because we won't
vignette
get
is not
progress.
really clear what the problem is,
Yeah.
and sometimes what's
Okay.
useful for the mother is not what's useful for the physician.
Yes, so
And you have to
you have
decide.
you have this mother coming with the coughing child. She cares about her
Mhm.
daughter,
She
her
wants him
son
to be safe,
to
and
be
she wants him to
healthy,
feel well,
to stop coughing and to feel well.
right?
So now you're looking, you've gone to the literature and you want to, you found
I'm
this
looking for
article.
the outcome that I want this child to be safe in Israel. I don't want to release him quickly. I want him to be safe. I don't want to have a rebound.
Okay, you
Okay.
found the article, this
Okay.
article, and keeping that in mind, now we're gonna see if this article
Answers my question.
answers your questions.
Okay.
So what we do is first we said we look at the validity of the results. If you remember the three main things. Looking at,
External or internal. Like, so we talk about the external, after the internal validity. Like
we're gonna look at everything.
every
And what we need to do is you have this checklist,
Mhm.
okay?
Yeah.
So go to the second page of the checklist,
Yeah.
which is here,
Mm.
and we're gonna follow the checklist to check the article, and we're gonna work through to see where we find everything and how we can read it. But just if you can not look at the article for just a second and focus with me before we start the analysis. In terms of validity of an RCT.
Okay, so and that relates to what part here?
It relates
What
to
number?
A, to all of A. Are the results of the trial valid? Okay,
What page?
Question number 1.
it's,
Question number 1.
yeah, it's question 1, 2, 3, 4, and 5, and 6. All of those are under section A, which talks about the validity of the article.
Okay.
Okay, so it's very easy when you're talking about validity to remember for RCTs, we want to find something that's called the elements or Rambo. Have you all heard of Rambo before?
Okay.
Okay, so what is Rambo? We want to look at the first R is recruitment. We want to see how the patients were recruited. If they were recruited, randomly, or if they were recruited, just from the street, or how. It's very important for the author to examine recruitment. The A is allocation, and here, this is talking about randomization, how the randomization was done. It's different, as a researcher or as a clinician. We'll talk about this in a bit, but the best way to randomize is using a computer program where you have no way to,
Manipulate.
to manipulate. You'd be surprised. Sometimes in the past, they used something like brown envelopes, and you put who got what treatment in an envelope, and then, they gave it, but you'd be surprised at how many times the secretary will switch something, or something, happens, and the randomization is flawed. So we need to see how the authors consider randomization and how it's done. Maintenance is important. For the M, was there complete follow-up of all patients? And here, when you randomize into 2 groups, the patients who are in the intervention should stay in the intervention the entire time. You cannot cross them over. Okay? And the authors need to consider, in terms of measurements, when they're making their measurements, what happened to the patients that dropped out? What happened to patients that died? What happened to patients who, they went halfway through the program, or they took the treatment half of the time and then they stopped? It's very important when we're looking at measurement that the authors consider this. And there's something called intention to treat analysis, which the patients that whatever group they're randomized into, even if they drop out or even if they die, at the end, the results are done so that they stay in the same group that they were randomized.
Even if they switch?
Even if they switch, even if they drop out, you should always consider them, in the group that they were randomized. And the B is blinding. If it's
Just
possible.
so measurement, it says, are they similar?
Yeah, are they similar at the start of the trial? If usually like the different groups, the control group and the intervention group,
They can be treated similarly because that's the intervention.
Other than this.
other than the
Ah,
intervention.
okay.
I'll give you an example. Let's look at this. If they're similar at the start of the trial, usually you'll find a table that shows, the characteristics of the intervention group versus the control group, and then they'll do a statistical analysis, a chi-squared, I think, not a chi-squared, yeah. No, it's not a chi-squared, it's some kind of statistical tool, and they find out if they're similar enough from the start. That's important that they do. When talking about if they're treated similarly, this is aside from the intervention. A lot of times, if you're doing interventions, maybe, and patients are meant to get one thing, but, as a side, they also get information from the doctor, education, that might also, impact the results. So it's important to recognize this and to see what was done. In terms of blinding, this is, does the researcher and the patient know what treatment they're getting or what they're not getting? It's the best type is to be double blinded. We don't want anyone to know what's going on, but obviously sometimes that's not, possible.
Jumana, what we should know about the patient that are dropped out or died or some, what information is essential that we like to know?
Well, when we're looking at critical appraisal, what's important for you to know as, someone who's looking at the evidence is to make sure they've done intention to treat analysis and to make sure they haven't crossed over, the groups.
But
So if
sometimes
someone
there is a crossover, even the RCTs.
that there is a crossover and that's a limitation. But what's important is that at least the authors recognize that and they write it in the limitations that they couldn't.
He got worse, so
Yeah.
I had no choice but to try and give him.
Yeah.
Yeah,
He
But-
was on the
Yeah.
placebo group, but he got so worse, I had to treat
It's
him.
like
Yeah.
to-
And you have to write why.
yeah.
Like, why
Yeah.
did he switch group?
Mhm.
He switched group because
You need to take the other medication.
Your job as a reviewer of the
To
evidence
see that they-
is to see that they've done it. It's okay. It's real world sometimes and
Mm.
things happen,
Right.
but you have to explain that it happened.
Mm.
So it has to be in the
He
article
had
that
another
this was
disease
done.
where hypertonic steroid is a treatment, so I had to give him from his other disease.
And then, we have to be objective. The researchers need to be objective. They need to be, aside from the experiment, they need to be treated equally.
So what's the difference between O, objective, to the second M, where the intervention and control groups treated similarly? What's the
They're-
difference?
They're similar. It's just,
Like taking the same medication for.
the B and the O are actually they're related to measurements in the Rambo, okay? So when we're talking about recruitment, we want to look at if the subjects, if the article actually clearly states what the inclusion and the exclusion criteria was when selecting the participants. Okay, we need to look at the setting where everything was done and how many people from the onset dropped out, how many consented to participate, and how many were included. So let's look at let's take a break. Let's look at our article and go back to our checklist. And let's try to go step by step together. So the first question is, did the trial address a clearly focused issue?
Okay.
Let's look at what was the population studied?
Maybe have to know what's the question.
Present with reason with the image.
Okay. And is the intervention clearly described?
Yeah.
Where do we see that? Can you read it out for us? In the methods, good.
It's like, on admission to the image, all children received one inhalation of normal saline with flubuterol. Minutes after inhalation,
So they compare our children with
okay, consent. Eligible patients whose parents agreed to study and assigned the consent were randomly assigned to double blind fashion. The 1 or 2 treatment group 1 treatment group received 2 more inhalations of hypertonic saline with 0.5 milliliters of albuterol at 20-minute intervals. In the emergency department, group 2 received inhalations of normal saline, 4 milliliters each, with 0.5 milliliters of albuterol in the same manner.
Okay.
So
So,
that's just about the
is it defined well?
Yeah.
It's defined, right? It's clear.
Which
Um,
one? Where are we?
Oh, and then we're here. No, we're not.
Sorry.
What are the outcomes according to the paper?
What's the-
Just a second.
Yeah.
The first question say like it's about what's the question of the study. Like they are talking about the loss of length of stay. This is that question.
Is that the outcome? That's the outcome.
That's the outcome.
that they are looking for.
Yeah, exactly.
Yeah.
So it's defined, right? So what can we answer this question? Yes,
Yes.
you can tell, right?
Yeah.
Everything is clear.
Yes.
and- Okay. Let's move on to the second question that deals with randomization and recruitment.
Randomized.
Mhm.
Written in the
Doesn't say exactly how the process was done.
לא, זה לא, זה לא, זה לא, אתה לא יכול לדעת איך
Can you read us the relevant
Yeah,
sentence?
can you,
Can you
How
read us
was
the
it
relevant
randomized
sentence?
double blind?
Yeah, they said, it's randomized, they don't say it was by computer, they don't say it was by.
אולי תיכנס לשיתוף בתוך המאמר, ואז תראה, יכול להיות. אולי
אם
זה-
אחות בטריאז' אמרה, זה כן, זה לא, זה
לא.
כן, זה לא.
It does say, let's,
They should say-
Isn't it enough that they wrote that it's randomized?
No.
Not enough?
it's not enough that they wrote that it's randomized.
But
If,
you have to know how. they
Okay,
randomize it.
that's a good point. If the paper just writes that it was randomized, and then they move on and they don't say anything else about randomization and how it was done, that should get you thinking,
Right,
why?
Because
Did
they're saying, they might have said that the nurse in the triage, because she makes, there are two ways to do it. Either they have syringes already made up, half of them with hypertonic, half of them with normal saline, and the nurse doesn't know what she gives, that's double blind. But if a nurse decides that for one patient she's gonna give that, for the other she's gonna give, the physician doesn't know, but the nurse also can, by the sight of the child, to go to this
But
way
you
of it. So
assume
it's
that if
not,
they wrote that it's
no,
randomized.
but they didn't say how, so I want to know how they did it. If they said the triage nurse decides, but the physician doesn't know, for me, it's not randomized.
Yeah.
It's not blind, because the nurse is not blind to the situation of a child.
So we should get.
So they have to get syringes that looks the same, but by numbers, you know which is which, and the nurse doesn't know what she's giving. That's completely randomized. And then they don't say it here.
Okay, let's look at, does it say, let's read, take a few minutes to see how it was randomized. Do they say it?
Yeah, the statistician delivered two
Yeah.
random allocation sequences of this.
Randomized.
Computer generated one for children under 3 years, and another for children over.
Okay, computer generated, is that a good way to randomize?
Yes.
Yes, it's the best way, right? Okay, so-
בעמוד
בעמוד.
699 למעלה לדעתי.
so what's the answer to this question?
Yes.
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 Okay,
Mhm.
let's look at question 3.
Yeah.
Were all of the patients who entered the trial properly accounted for at the conclusion? What's the easiest way
Again,
To
were
find
all the
this.
patients who entered the trial
properly accounted for?
What does it mean?
Okay, were all the patients who came in that were recruited and agreed to participate at the end? Do you know where all of them are, what the
Okay.
data from all of them are? There's one way to easily find this information. And that's to look at something that's called this flow chart. All randomized. Do you see this
Mhm.
on page
Yeah, they
1401?
started with 61 and they finished with 41. 20 patients didn't continue. that's excluded.
אתה יודע מה קרה.
אז 41
Okay.
נכנסו, yes.
So what
41
I,
get in, 41 go.
Yeah. so what I want you to recognize or to be aware is that always all randomized controlled trials that are published should have a table like this or a flow chart that simplifies things for you. So instead of you spending a lot of time reading in the methods and what happened and in the results and where they went, look for this. The first step you should do is look for this flow chart. And they started out with 61, and from the very beginning 20 of those were excluded because of the different exclusion and inclusion criteria. And then we ended up with 41, and those 41 were randomized into 2 groups by the computer program. Now, looking at the 2 groups, looking at this flow chart, what can you tell me?
They're not equal in size.
They're not equal in
If it's
size.
randomized completely
Yeah,
by
but
the
it's only
computer,
41 patients, so it's like.
yeah, it's a small sample,
It's a small
and they're
sample.
not equally distributed.
But I'm
If the
saying,
computer is,
when it's so small a sample, it's very common to have, and it's randomly
Right.
assigned, it's very common to have not equal.
That's true.
size
Now,
groups.
do you know if all of the patients were accounted for at the end?
yes,
Yes.
they started 41, they
Analyzed
finished
5
41.
and
Yeah.
16.
Okay.
6 and plus 1.
So that's a good thing.
Yes.
So
So that's a
that-
yes.
that's a yes. It adds strength to the paper. Because sometimes you'll see, you'd be surprised how many articles they start with 2 groups. There's 100 in this group and 100 in this group. And then in the end, for some reason, there's only 94 here. So that should get you thinking, you know,
Why did they get them up?
where did they go? They shouldn't go anywhere. They should be, even if they dropped out, they should be accounted for. Okay?
So what
Sorry,
could be-
if they
what could be the
start
reason?
100 here, 100 there. But then 4 children left the country because they went abroad. How can you analyze what happened with them?
You don't.
You have to report.
You do, you report it and you do this intention to treat, to the intention to analysis. And you keep the groups, even though they dropped out, you know, your first inclination is to put those children in the control group. Because they dropped out, you can't really examine the effect of the,
Right, you can't.
of the, yeah,
Your natural inclination would be to just exclude them from the study. from the
Exactly.
analysis
to
altogether.
exclude them.
Not even in the control, because you don't know what happened to them.
Yeah.
Some people, you know, they recognize that they shouldn't take them out completely, but they move them to the control, and that's wrong. So
Yeah,
if,
that's wrong. You shouldn't
say to the control without
can't.
knowing what the
Right.
outcome was.
yeah,
According to
can't.
you can put them in the control, but you can say that you started with 100, but 4 left the country, immigrated, and then you exclude them.
But when
So
you
start with the
analyze,
100.
You don't exclude.
you don't,
It's
yeah,
only the ITT. But you have to mention
אומרת
that
שהם
4 of
dropped
them
out.
lost of follow.
כן.
Lost of follow.
Lost of follow. And then the statistics
לא
has
excluded
to take it
dropped out.
into account.
and you,
אבל בסוף יהיה לך נכון.
you do something called, I'm not gonna get into this, I don't know.
שככה עוד חץ ואלה יצאו.
You don't, I'm not gonna get into what the specifics are, but you need to see if this happens.
Why?
They
What
need
happened?
to, they need to do, it needs to be written why
What
it happened. And they need to do an intention to treat analysis.
What's an intention?
It's a statistical,
population.
yeah,
I think it's
All
saying
the
intention
patients
to
are
treat
behind.
analysis.
It
is-
keeps-
Is more relevant when you have crossover, when people, they don't get the actual treatment they were assigned to randomly. And then you say, okay, so I can look at their actual
Exact-
outcomes, but I need to look where they were randomized. And the reason for that, as I understand it, is that the question we're addressing is what decision we want to make. So, okay, so this is the question we're answering if we do an intent to treat analysis. And if we do just an intention of what the result of a specific treatment would be biased because, I mean, it's not, it would be biased because sometimes patients will not receive the whole treatment for various reasons. They would, you know, so answering the question of in the point in time when you have to make a clinical decision, so the best type of analysis would be the intention to treatment.
yeah. And it's keeping it's as the people were randomized, that's how they stay in
Okay,
the,
that I understand.
yeah.
But what's the intention to analyze? I don't understand.
because it keeps, it's a
What's-
statistical way, you don't need to know.
Imagine if you have 2 groups and they were assigned to different treatments,
Okay.
and then you have a crossover of 5 patients from one group, they were treated with.
You
the-
don't
with
move
the
them
other
there, you see.
Yeah,
you-
in the
you
end-
leave them in that
But you
group.
don't analyze it, but you don't.
No,
analyze
you
it.
analyze.
How can you analyze if they didn't get the treatment?
So what? Because the
You analyze.
intention
Yeah.
to treat them was with the first.
Like even if they go to the other group and take the other medication and they heal, you consider them like they to be in the first group.
5 children didn't get the hypertonic saline. They were supposed to, but they didn't get. You put them in the statistics.
Yeah, because
the group
because that happens in real life.
Yeah.
That's
Yeah.
kind of the type of thing
You know-
that happens in real
Because,
life.
no, because it's-
Crossovers and stuff.
you want to be safer than sorry, so.
Yeah, it's conservative,
It's
so it's better for
conservative.
you to be, yeah, to have data that's not as strong than to have data that's wrong, because if you include
Because there
those,
was
in
a
the- yeah,
reason they didn't,
Good for that.
Yeah.
either they had too many
No,
side effects or it was.
no, you have to be conservative,
תסתכלי בתוצאה,
Even if-
יש לך 10 ו-23, כן? בטבלה האחרונה, ב-1402. יש לך
אני מבינה למה זה לא עובר
אז
שתוצאה. למה לא
admission rate 10
זה
לעומת
הטיפול
23, כן?
it's, yeah,
אז זאת אומרת, 10
It's
נתן לזה
if one moves to
מורכבות.
another group of
כי רק
treatment,
כמעט
you
הצלחתי
like,
להוריד
you-
עם
at the end,
האלקטרוניק
like,
סלע
כן.
את האשפוז.
consider
אבל
them to
4
take
הלכו
the
לך
first
לאיבוד
group
נניח.
yeah, you still
אם
have to
4,
analyze it according to the
as
first,
he
yeah.
he was.
However, they were
Yeah.
מיד
randomized,
הופך
yeah.
לך את הסטטיסטיקה.
אבל הם לא קיבלו, אז מה זה
4
עשית
לא.
מהסטטיסטיקה?
4
לא.
לא. אז לא יכולה, את חייבת לדווח את ה-intention to treat. הכנסת 41,
זה אומר,
צריכה לדווח על כל 41.
כאילו
ואז
היינו
אני
בקבוצה
קורא את זה
של-
קריאה ביקורתית,
Mhm.
ואני אגיד, הופ, פה הסטטיסטיקה שלה בנויה על 10 לעומת 23, ונעלמו לה 8.
הבנתי.
איפה?
המאמר
כן.
לא כל כך טוב.
הבנתי. הבנתי.
Usually it's not a
נעלמו
one
שונה,
but
כי לא
נעלמו
הצליחה,
שונה.
כי זה חלק מהעניין לשכנע אותם
נכון,
לקבל
נעלמו,
משהו.
לא יודע מה, אצלנו הנתיב. מתו זה, אז אתה אומר, מתו עשו MRI, כן? עשו MRI, אז אתה אומר, מה קורה פה? לא הצלחתי להוכיח באמת.
לא הצלחת, הבנתי. עכשיו אני
נהיה
מבין.
ביקורתי.
Just, yeah, be sure that you know, like the main
בסדר.
point is that when you're doing
זאת אומרת
RCTs,
שזה
if
חלק
people are
מהדברים
not
שקורים בחיים שחולים
accounted
מתים,
for,
אתה צריך
it
חוזק
needs to
מספיק
do
גדול
attention to
שלוקח בחשבון את זה,
נכון,
שחולים שלך הם מבוגרים ויכולים למות מסיבות אחרות,
נכון.
אתה צריך לשכנע אותי שהתרופה הזאת מצליחה לעשות שיפור למרות כל האלה שהולכים לך לאיבוד,
נכון.
שמשום מה הלכו יותר בקבוצה הזאת מזאת, אבל זה יכול לקרות, ושאין לזה מספיק תופעות לוואי, אז שכנע אותי לחומרה.
נכון.
זה מה שאתה אומר.
כן.
אוקיי, עכשיו הבנתי.
Okay, so
תראה שזה
let's
בעברית. אני כבר ראיתי.
נחמיר.
let's move on to question 4. I think we've answered this before. Were the patients, health workers, and study personnel blind to treatment?
Here, yes, it was a
Yes.
computer and they had this nebulizer, no?
Was double blinded?
Same.
Okay, so there we can say yes. The next question, were the groups similar at the start of the trial? Tell me where-
Table
Why?
This is table 3.
two. Epidemiologic article.
16 לעומת...
Look at-
And the parents.
למה? יש להם כתוב
It's 2 and 3. Let's
two הם לא כל כך דומים. זאת אומרת, הג'נדר לא דומה.
look at the P. If there's, you know, they might be a little bit different, but the P looks at if they're statistically,
similar.
are they similar?
Because the P is
Yeah. There's nothing that's statistically significant, right? Okay,
נורא מוזר. ג'נדר, פימל טו מייל, בהיפטון סלן זה 9 ל-7, ובנורמל סלן זה 19 ל-6. איך זה יכול להיות? אז מישהו עשה את הפי, איפה שם, אבל מה?
That's significant.
כי זה,
Maybe it's
כי
because-
צריכה להשיג מטבע,
Yeah,
אבל
it's
פעם,
small.
זה לה, כאילו, מה לעשות?
there will always be differences. We just want to see if they're statistically
זה חוק
significant.
המספרים הגדולים?
כן.
זה הפוך
כן.
לחוק המספרים הקטנים.
מה אומר?
סתם, לא, אתה לא יכול לצפות בחוק המספרים הגדולים.
אבל זה אומר שהאוכלוסיות לא דומות, אבל חובה זה.
התחיל אותו רק 40.
אבל זה הכל
אפשר לעשות את ההנחה הזאת, אבל אי אפשר לעשות את ההנחה הזאת פעמיים. אם בחרו מחקר עם 40 מטופלים, וזה בגלל זה לא מתחלק בצורה שווה בין בנים לבנות, בשתי הקבוצות, בקונטרול ובזה, אז אתה לא יכול להגיד שהקבוצות דומות. איך יכול להיות ש9 ל7 דומות?
הן
דומות
שונות?
בטווח הטעות.
נכון.
Okay, let's move on to the next question. Aside from the experimental intervention, were the groups treated equally?
Yes, בחמש.
Okay,
זה לב כבד, אני מסתובבת.
were the groups treated equally aside from the experimental intervention?
Just a minute, and how do you decide which P you want?
If
I know that
Yes.
0.03 is not, you look for 0.0 or something. 0.01.
You should look for 0.05 in this case.
Why? How do you decide which P you decide?
I mean, if you want to be more conservative, then look at P.
0.01, that's what I know.
That's
Why do we decide here that 0.6, you have here 0.6, you have 1, you have 1, you have 3 ones.
It has to
But the
be
P-
0.0 some.
has to be 0.0.
No, it's not, so it's not.
It's up to
it's
you.
not-
Significant, so
yeah.
they're the same.
זה מה שטוב, שההבדל הוא רק
You can,
קבוצות דומות בהתחלה.
הבנתי.
בטבל 1,
שההבדל פה הוא לא, הוא מעל,
הקבוצה שהוא לא
and you
יעשה.
can decide if you want your significance to be more,
But the authors also say which significance they use, don't they?
yeah, they use 0.05 here. Okay, so let's look at the next question, which is aside from the experimental intervention, were the groups treated equally?
קיבלו שם, קיבלו אותו דבר, סטרואידים בהתחלה, אחרי זה, מה זה?
This is in table 3.
איפה אתה רואה?
In table 3 it says one for the later treatment,
זה לא,
oral steroids. And it's kind of the same.
It is.
Except bronchodilator treatment, but p-value 4.4.
There's nothing that's significant.
It's not significant.
Yeah, so pretty much we can assume that they were treated the same, right, in the table.
But it's really interesting because 80% of more children of the 25 compared to 68% of less children. 16. So the statistics is not there. So
Where are you looking?
What?
Table
table
3.
the
Yeah.
treatment, bronchodilator treatment. I would argue that the groups are too small.
זה מה שאמרנו
And
קודם.
we don't
Yeah.
know the exact statistics because 80 out of 25.
נתחיל מ-40 עד 40 ילדים, 16 ו-20 בטיפול
And that's
כזה.
an important
תופעות
point
לוואי
when you're
של-
making your decision
That's
on how to, yeah,
פורסם
That's why I took
בפידבק.
these papers at the numbers.
of course, yeah.
לא, זה פורסם
Okay.
בפידבק, אז אני לא
So,
יודעת מה יש לזה מסקנה
Here we can
שלהם.
say that, you know, yes, it might be a little bit. So now we're going to move on to the next section, next question, number 7. How large was the treatment effect?
איך נגדו את זה שנייה?
אבל הוא קטן לו.
How large was the treatment effect?
הכל.
אבל
אבל אם יש
אמרנו
סיפור,
לך,
אם יש סיפור שמופיע 1 ל-1000, אתה לא תגלה אותו ב-40 ילדים.
ישראלים?
צריכה לבדוק.
בגלל זה systematic review זה יותר טוב, כי הוא
נכון,
לקח הרבה
נכון.
randomized control trials והתחבר אותם ביחד. אז
אוקיי.
בואו נעשה את שאלה 7, how large was the treatment effect?
נכון, זה סלעים שילדים בכל הזמן.
אתה יודע כמה עבודות של קרטון אקסלנט
זה
בילדים? כל אחד
Here, when we're talking about the treatment, we should think about, you know, what outcomes were measured. Is the primary outcome clearly specified? What results were found for each outcome?
הם רק בדקו discharge from the hospital.
admission rate and discharge and
Admission rate.
LOS. And
What were the
also
findings? What, you know, what's the conclusion from the
So the
findings?
normal saline
It's-
group
there's-
has
there is,
much more hospital admissions, hospital admissions than the hypertonic saline group, and it was statistically significant.
Okay, where are you seeing this?
In table 4, it's the first line, that's 92% to 62%,
Mhm.
and it's significant.
Okay,
this is for you.
And the length of stay is also significant, and that's
All of them, all the
they were hospitalized for longer.
So normal saline,
כאילו מקצר,
deteriorates, זה
הפטונית
deteriorates
מקצר.
the clinical outcome of a patient, normal saline.
It's a good thing.
That's my
You can use it.
לא, קונקלוז'ן זה ההיפרטוניק יחסית לסטריין רגיל,
לא, normal
הם לא
saline,
עשו יחסית ללא טיפול.
normal saline זורק אותו לאשפוז.
לא, נורמל סלן זה הסטנדרט. סטנדרט באינלציה,
זה
אתה
מה
שם
שהבנתי.
עם הסטרואידים, עם הסטרואידים אתה
okay.
שם נורמל סלן.
So-
It looks like it helps in everything, like admission rate and discharge from the hospital.
normal
אשראי
saline,
בין היפרטוניק
Yeah.
וזה היפרטוניק
So-
מקצר.
normal saline is detrimental in my understanding.
So we see that, you know, the results are clearly described. We find them in a table, and that's what we want. Let's move on so we have enough time to finish.
But, Joanna, how you can quantitatively like say about how large was the
מה כתבת
effect?
פה?
Like it's like in long LOS, like 2 compared with 3.
It's very small numbers. That's a limitation of the study.
But
You
what is
can't-
the answer to this question? Like,
That there was a significant effect.
oh,
And
no.
what? How large is it? What? Like
It
it's large?
bothers me.
Depends on the field.
It's such a small sample in trying to answer these questions, but I think this is something for statistician to explain.
And I think, you
Is
know,
it powered to answer? Was it powered enough to answer the questions? I mean, it's such a.
Should we
sample.
change management with children coming to my ER based on 40 children?
No,
Children,
let's do
no.
a systematic review and
Let's- let's look at the power
Seriously.
calculations were made. Power calculations were done. So in terms of statistically, it's okay, but then as a physician, are you really going to base your treatment on 16 kids? On what
Yeah,
was
but
done?
that's
That's why you
actually,
should,
that's
Your
the
point is
question.
going
but
to
Yeah.
how do you
That's
answer
your
this
view.
question? Not like,
you go to a
However, you
systematic
find-
review.
systematically answer such a
You
question.
You go to a systematic
I'm
review.
counting on the statistics to tell
Yeah.
me.
ויש אנשים שעושים את העבודות, כל מיני
Statistically
עיבודים
significant.
יושבים,
I
עושים,
can
מוצאים
decide for
guidelines,
myself.
אחרי שהם קוראים את כל הדברים
Clinical
האלה,
effect
הם
is
עושים את העבודה.
relative, is important enough. but I
באמת,
rely on this.
אני
statistic.
That's why-
American
that's why you should
40
go,
patients is enough. 40 patients are enough.
that's why you should go to a systematic review and look at the meta-analysis and look at all of the studies done on
If
this.
you have a rare side effect,
Okay.
you always have to
There's
consider,
something that we're not.
you have to consider the benefits and the risks.
For sure.
So you have a benefit, okay, you have a benefit because you lower admission rate, blah, 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 okay?
Nice.
But then you don't know if you have a rare side effect, is it worth it? If one child is hypernatremic, okay, and gets hospitalized in intensive care unit for a week, just saying, and it's 1 to 1,000, you're not gonna see it here.
Mhm.
So you're using a new treatment without knowing the side effects. That might be
Yes.
rare, but they might be more serious than 1 day of hospitalization of a 4-year-old.
Of course.
So that would, I would say that's the kind of out of the scope of this.
That's what they're talking about
But this is-
immunization right now.
This is for you.
Because if they did,
That's,
I don't know, 1,000 kids, they gave them the corona vaccine. So the children are not very sick and they depend on the disease in the adults. So is it justified to give them corona vaccine, not knowing if there's 1 to 2,000 chance they're gonna get something?
and that's
Side
when your
effect?
clinical judgment comes in, and
That's-
it depends
that's
on
the
every
discussion.
physician and every case and
That's
to make the
discussion
decision,
now.
yeah.
If
Okay,
children
let's,
are
let's
very
continue.
sick of corona, then okay, you say, okay, if there's 1 to 2,000. I
Risk
might take the
benefit.
risk.
yeah. Let's move on now to see if, Donna, as the head ER doctor in her department, if locally she thinks this is applicable. So can the results be applied to your
Yes.
own population?
Easily.
Why would you make that
No.
decision?
Who are these kids?
No, it's applicable. I'm not gonna use it because it's for the kids and I'm not convinced, but.
Who is the
But who is
population?
your population? If you remember back to the case,
But
how old was the case? The child and
Shall
the,
apply, maybe you not-
Child was 4.
the child was 4. Is it the same population
Yes.
group that's in the study?
Yes,
Yes.
we have
Let's-
hypertonic saline in the ER. We use the same nebulizer.
יש לכם את
So
הציוד.
Is it,
יש לכם הכל.
in terms of cost?
Computer program, יש לכם כזה דבר?
לא, אני לא צריכה את הקומפיוטר
What?
Are you asking, can I apply the
The-
research?
No,
in
the
my-
treatments,
The
the
results.
results, the results.
אוקיי, אוקיי.
Yes.
Is there any kind of side effects?
I don't
So
know.
we don't know.
Okay, so what would you do in this case?
I'm not gonna use hypertonic saline.
באמת?
Not
Yeah.
based on
You're
this
gonna
paper.
do- you're gonna do
זה לא-
I'm gonna do systematic review, and systematic review, you have papers saying this.
לא, בסדר, זה לא השאלה, השאלה זה
What did the
ליישם.
mom want?
אז
כן,
ליישם,
אפשר.
What does
אתה
that
יכול
mean?
ליישם,
Help
אבל
with the
אם יש
coughing.
תופעות לוואי שאתה לא יודע אותן,
זה שאלה אחרת.
לא,
זה,
לא מיישם, זה השאלה הבאה. ליישם אפשר ליישם.
זאת השאלה.
Outcomes considered.
Okay, so
נכון, וזה לפי
We're
את זה.
at 24.
Okay.
So that is kind of, we've done, a very fast run through. Obviously, if you have enough time, we're reading the full article first. And then we're doing the checklist in a systematic way to make sure everything is, it's appropriate. And just to think about the elements that we talked about, are the results valid? Check according to Rambo, if there's randomization, if there's allocation. Again, there might be an issue with one element, and that doesn't make it a bad article or bad evidence, but the researchers need to explain why. They can't just say it was randomized and not explain how randomization was done.
Right.
That's, that should get you thinking that there's something flawed with this research. And maybe you don't want to base your decision on this.
And again, you say we don't need to understand very much about the statistics, but I feel like after we did all that, and most of the question we answered yes, still the validity statistically, for me, it's a black hole here.
Yeah, it's
Because it's
important. I know you
events.
have a session on
If
statistics.
you convince me that
We have
Two
3
groups,
sessions. on
25 against 16 with female to male ratios that are completely different, that everything is statistically the same, then for me, I feel like there's something, like someone is tricking me.
Okay, and
He's
that's,
playing with the numbers and tricking me,
Yeah, I
because
hope-
how can it be that you have 9
Yeah.
to 7 is the same as 19 to 6? Like,
Yeah.
how can you say it's the same group?
and I hope,
Female to male ratio.
I hope that, after you have 3 sessions on statistics, hopefully after those 3 sessions, you'll be able to better
More
understand.
girls were treated more girls, absolutely, and in ratio, we're treating with normal saline compared to boys.
Mhm.
So maybe girls are more resilient to treatment, and if they were in the other group, they would not be released, and it wouldn't be 10 to.
Maybe.
In
I mean-
children 2 to 6 years old, do you think that there is
I don't know, maybe they are different.
difference between
They,
boys and
I
girls?
don't know, they are different.
Maybe.
They are different, they have
But,
different hormones running, they have different voices, they have different body structure, all their growth is different.
And I think
the
that's a
development
good,
is
you know,
different. Boys and girls are not the same.
You're making a very good
As a
point,
group.
because as someone who is
As a group.
reviewing the evidence, all of these are valid questions that you should be asking.
Right?
And you know,
Because they say statistically they're the same group, okay? They
no,
give
they're
them
statistically
0.3.
not,
Are different.
And
there's
again,
no
0.3 is
statistical
very, very
significance.
close. It's not one, it's not very far.
yeah,
It's 0.3.
No, it's
But
not close.
It's
because
not close,
It's not
it's
0.05.
Also the age,
Okay,
see?
But,
30.
okay, so
But
what we're
let's-
gonna,
אני יודע למה זה
Imagine.
מעצבן אותך.
And
we're
the range,
gonna-
see the age range in the normal saline group is much bigger. So is a 2 years old is completely different than a 4 years old.
Yeah.
And here you have a very large,
and all of those are
distribution.
points, yeah, that you should consider. You're right.
but then if
So,
you
but-
want to, but then when you answer that question, where is it?
You can put can't tell
Where
or
is
no.
it?
זה מעצבנת.
לא קשור, אני אומרת,
פשוט-
אתה לוקח טווח של ילדים פה, מגיל מתחת לשנתיים.
תוריד את ה-
Look,
So
also
in
look,
question number 5, Dana, in question number 5, instead of saying yes,
You can say can't tell or.
the youngest child in the normal saline group is less than 2 years old.
It's something that you answer on a whim, right? The statistics say that it's.
Right,
No,
but if
no,
you
no,
have
no.
doubt, if you have
You have to
doubt,
understand the
then
statistics and what it means.
So I would
for
answer
me-
yes, but then I would comment on
Look,
this. Why is
The
that?
youngest child in the normal saline group is less than 2 years. The youngest child in the hypertonic saline is more than 2 years. These are two completely different physiologically.
okay, but
Children.
we're not gonna, we'll continue.
So we've done,
One more thing. If you take a 40 years old and you say the distribution, it's important. If you take a 40 years old man and you say the distribution between the ages, okay, so in one group you have plus minus 2 years and the other one you have higher distribution and plus minus 3 years, it's not different.
yeah,
But when you take
children.
2 months at the age between 1 year and 4 years, every half year has a significance physiologically. So you cannot, it's not just the difference of the ages. It's not the same when you do it around the age of 40 or around the age of 2.
You're exactly right. And
So
because
so
of
for me,
this, the
it's
best
easy
type
to
of
put the
evidence.
numbers and say 0.3.
Yeah, the
But
best
it's
type
not,
of
because-
evidence you could find is an article that's specifically for your age, different age
Right.
groups in the case of children. But unfortunately,
Yeah.
you know how it's not very feasible a lot of times to find evidence that,
I'm sorry,
is only on 2-year-olds or only
19.7
on-
months, it's not preschool, it's a toddler. It's a toddler, it's not a preschool. So for me, I rest my
Okay.
case.
okay, so,
So now, please continue, Jimena.
no, now we're gonna take a break.
Now we're gonna take a break and it's a 15-minute break because we have breakfast in the kitchen.
Thank you.
כן?
That's the
אבל השאלה
אני מבין.
אנחנו צריכים להבין כיצד זה רק טורבינות, או שדעתך לעשות בחוץ ניתוח אחר, שהוא משהו
Okay,
קומה
נייט. הנה הרופא שאני
אוקיי.
דוקטור סקר לא, טוב, אנחנו מתחילים פה איזושהי הרצאה.
ומה שאני
כמו זה
מציעה,
דרוגה,
תראה
עוד שעה, מה זה?
תראה, תלוי כמה חולים יש. 10 סטודנטים.
לא,
יש 5 חולים.
אני דוקטור
בסדר,
סקר.
הנה לך עכשיו. לא, לא כולם זה מתאים שאתה רוצה. התורן שיספר לנו עליו, או ביחד לבדוק אותו, לדבר עליו.
אז בואו נמשיך.
okay, so we practiced with the RCTs and you had the chance to see the tool, the checklist for the RCT. Now we're going to move on to a systematic review. And as you know, that systematic reviews with meta-analysis are of higher quality because we don't have the problem that we saw with the previous RCT where there's such a small sample size. Here, it looks at all of the evidence that has been published on a specific topic. So I don't want to be repetitive, but there's the 3 steps that we always look at. And just something that you should be familiar with is that an important point to remember is that systematic reviews are only as good as the studies on which they are based. Because they're secondary research, they're based on the results from the primary RCTs. So keep that in mind. So you can't, really, if you have a systematic review that was done on poor quality evidence, then obviously the systematic review is going to be of poor quality. What I want us to do now is to break it to groups. You can have one group of 2, one group of 3, and look at, you all should have brought in a systematic review. And I have the checklist, if you'll take one and pass it around. And we're going to go through the same thing, but now in smaller groups with your checklist. But before, the way you look at things is a bit different in terms of validity. Here, when we're looking at a systematic review, the validity really depends on different elements. We're looking to see, first of all, if there's a clear question that's being answered, on the types of papers, the types of evidence that is being looked at. I don't know if you've done systematic reviews before, but you should have at least 2 independent reviewers who are examining all of the articles and looking at all of the, yeah. So that's important to take into consideration. Look at the results if they're valid, if you think all of the important and relevant studies were included. An issue that might result in publication bias is, usually research that is published shows positive effects or has an impact, but think of all of the researchers out there who have done different studies who have not been published or have not been able to publish their results. So what happens is that data is put into a drawer and it's forgotten about and no one knows actually what happened. So we really do need to take that into consideration. Sorry, I'm calling someone. We need to take that into consideration when we're looking at the systematic review to see if the reviewers or if the people who wrote the article actually made calls, made contacts with lead researchers to see if they asked about studies that were not published. That's an important point to be aware of. There's something when we're looking at the quality of the RCTs or the studies that are being reviewed. There's something that's called a JDED score that we usually take into consideration. There's different types of scores. There's the JDED or the Pedro, but usually it ranks the quality of the studies. And a good systematic review needs to have, this published in their article.
But in the article, the JDED score is so and so, the Pedro score.
Yes, you can
And
see
who gives those scores? The
The-
institutions that do that?
no, the reviewers.
The reviewers.
Yeah.
are doing
So here, let's take this first study. The score is based, it's out of 5. And there's 3 different categories. They look at randomization, they look at double blinding, and they look at withdrawals and dropouts and how each study dealt with it. So 1 point is given for randomization, 2 points for double blinding, and I want to say 2 points for withdrawals and dropouts for a total of 5.
This is something the writers of the article.
This is the person doing the systematic
it's not
review.
the reviewer. The reviewer is giving.
This is the person who is writing the systematic review. Okay, so
It's every study and
yeah, and scores it. And obviously it's done by 2, it should be done by 2 independent reviewers too.
and if there is a discrepancy between the evaluation, like the scores,
They go to a
Usually,
third
I'll
one.
tell you, they go to a 3rd one. Like I'm doing a systematic review now with Michael.
Yep.
Another one of my colleagues, Yanai, and I are looking at all of the abstracts and all of the, the studies. If there's an article that we disagree upon, I call Michael to get his opinion. And if Michael has a totally different idea, then we try to find a fourth person so that we can come into agreement.
And those people, they should have some kind of experience or rank or.
They should be
I guess
professionals
I cannot.
in the
score a
field.
At this stage.
You could.
If you're doing a systematic review,
You should be able to, yeah. It's specific criteria. It's looking at if
Was it
there was,
randomized?
yeah,
Check.
yes.
You get the point.
Yeah, if it's,
it was
if they talked
double-blinded,
about,
that-
how they're randomized and the quality of the randomization, you get a point. If they just say they were randomized, but then they don't describe how, you get half a point or 0 or whatever. Okay. So that's something you should look for in your articles.
Yeah.
From what I saw from the previous lecture, you talked about, how meta-analysis are looked at and how they're analyzed. Just another issue is when we're doing not all systematic reviews, you can do a meta-analysis properly. It's like, think about when you're comparing apples and oranges, you can't compare apples to oranges. So if the RCTs or the studies are so different in their populations and their different characteristics, then in their outcomes, you can't really compare them. You can't put them all, in the systematic review and do a meta-analysis and come out with a result that is, that's comparable. So they talk about something called heterogeneity. We don't want too much heterogeneity, which is difference. We want articles to be, not identical, but as similar as possible so that we can compare them. And the way we can judge heterogeneity is if you look at this chart in your studies, you have something called I-squared. You see here, this I-squared, here it's 20.9%. Usually, if it's less than 50%, then the heterogeneity is low enough that we can do a meta-analysis and compare it. This is good, yes. So that's something also that I wanted to share with you before you actually start reviewing your articles. די טוב, כן. When
So
we,
when people do multi-center studies with like 50,000 patients, that's instead of, it's better than doing a meta-analysis, isn't it?
it's not better, but it's very good.
Because it's
Should
more,
be good
it's
quality.
more homogeneous. They decide what's the population.
But it's
They have
only in
many
one,
patients, and they have the same protocol of the study, so it seems all these huge.
no, usually, huge studies like that are good quality. They're very good evidence. But, when you do a systematic review, it compares that big study with other studies too.
Mhm.
So
Okay.
that's why
Even
it's
bigger.
stronger. Yeah.
but
then it's more heterogeneous.
You learned how to read a forest plot, right?
you can repeat.
Okay.
We can go into it.
So the forest plot is how
Let's go.
it's a visual representation of the meta-analysis data, the results. So here you can see each study that was looked at. You can see the people in the population size, the people in the treatment group, the people in the control. And this is the risk ratio that they found. And just so you know, I don't want to get into too much details because you can have really a full hour on how to read this, but usually you can visually look at it and you see the bigger rectangles. The size of the rectangle is the size of the study in comparison to the others. So the bigger the rectangle, the bigger the study sample. So that's one way to make it easier for you. Also, you have this line, which is the line of no effect. If your risk ratio falls on the line, that means there's no significance. And here it either favors the intervention or it favors the control. In this case, this side favors the intervention. So you can see that in the end, when they did all of the complex statistical analysis, they came up with this big diamond at the end. And you can see that it's statistically significant. And the edges of the diamond are actually the confidence interval.
Therefore, it's significant.
Therefore, it's significant. Yeah. Okay. So that's just a little bit about the forest plot so that when you read it. Another plot that you'll see in systematic reviews is a funnel plot. And what a funnel plot shows is it lets us know if there's any kind of publication bias, which we want to try to avoid. Like we said before, you want to try to include all of the studies on a specific issue in the systematic review so that, there's no bias in terms of publication. And you can see here,
So
okay.
What's a publication?
Publication bias means that you only show in your systematic review the publications that support an intervention, that you leave out.
Okay, so you don't want to do that.
You don't want publication bias. You want to include the results
the
of all
good
of
and the
them,
bad.
the good and the bad. And the way you can tell visually is you see here with this funnel plot, if the studies, these dots are the different studies, if they are spread out, then you can say that there is no publication bias or minimal publication bias. If you see here, all of the dots are gathered, on the top left side, you can assume that some of the studies that may have found different results were left out.
But maybe it's a good treatment and there are no other results.
Maybe that's also, that might
Why
also be a
does it say
reason.
that it's not a publication bias. Maybe that's the treatment and that's the result.
In that case, you need to look at each, it's just a way for you as a reviewer to think, to maybe start thinking that maybe something is fishy here. It might not be, but as a reviewer, as someone who's reading the systematic review, if you see that all of the results are on one side, then you should start thinking maybe what was done here. And usually in the discussion, the authors will write.
If I will do meta-analysis of the היעילות של פניצילין ודלקת גרון. All the papers are going to be there.
Yeah, but there should be a
not
few
papers showing that penicillin doesn't kill streptococcus.
But there should be a few papers that are like scattered down here. And in the discussion, the authors of the systematic review will have said something about that. That's what you need to look for,
Okay.
that it's mentioned. Okay. So
Their interest to say something about it, otherwise it looks fishy.
otherwise it
No,
looks
I
fishy.
think it's also not, you would find the same thing, it would be a symmetrical plot, only it would be very skewed towards the effectiveness of the treatment. The fact that penicillin always works doesn't mean that everyone's gonna have the same exact results.
Yeah.
So that if the distribution is gonna be symmetrical, then it's.
מה החשיבות של הקו האמצע? What's the significance of this
כן,
line?
פה עם רובם בצד אחד, יש לך
There's no effect.
Yeah, it's just, this is no effect.
No, this is like the upper chart says that you include more studies that was published, and the right side is not published. What's the right to number one?
Like here, when you do the triangle,
Okay.
you see that there's studies over here.
All of them are
Yeah,
published.
they're all published.
Okay.
Here they show, different results are found.
Okay.
But here it shows all of, when you do the line here, it shows all of your studies found similar results. This is just a visual tool for you to start thinking about publication bias. You don't need to understand, in so much detail, just when you're looking at your systematic review, look for this. Okay? So that's it. I want you now to break up into groups and to look at the article that you
One of
selected.
them, because you're
One of
going to be
them.
in pairs, right?
Yeah, in pairs. And follow. Did I give you the tools? Yeah, I handed out the tool.
Yeah.
Make sure you're looking at the one that's systematic review.
Okay.
Okay.
Okay, so we'll give you what, like 30 minutes? Or?
Yeah, we'll give you. I just need 5 minutes to summarize and.
So the same as what we did together, now do it on our.
אנחנו מתחילים את ההקלטה.
Okay.
You're recording?
Okay, so I hope, I don't know how much, if you all finished going through the checklist, but I hope it really gave you the opportunity to kind of practice That's the whole point, with critically appraising research articles, it is practice, 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 and that really gets you thinking about, how to do things. So I just want to summarize. We've looked at the reasons why we should critically appraise, and I hope now you have a better feel for how to actually critically appraise articles, and that you aren't as overwhelmed or as, it's not really fearful for you now that we have our checklists and you have those available to you that you can use. So I'd like to just, hear a sentence from each of you of how you think, things went, if it helped you, what helped you most. ממש משפט אחד.
זה עזר לי מאוד, זה שיש צ'קליסט, אני עובד לפי באופן סיסטמטי, זה מצוין,
יופי.
ממש מצוין.
Yeah, I think the checklist is a great information. Obviously, we're reviewing the different problems with the assessment and what's important, but checklist is addition.
There are several איך אומרים, מקצועי, professional things that I learned after doing it for many years. For example, breaking bad news.
Yeah.
That there is a method, American method, and I learned it like 20 years after doing it. So this is the same. So it brings you in some level of depth.
Yeah.
What you know, and you actually you've been doing it. So
Yeah.
it's very good, even though I didn't practice, but it's good. I didn't know the Rambo. I didn't know about it.
Good.
I feel I have an anchor now. So I have where to start. I still have a lot of work to do because for me, if I don't understand what confidence interval is, I'm lost. Like I need now to start doing it and start reading about the stuff I don't know, and I need you by my side. I mean, it's a beginning, but I still really I need some more
Support.
a lot of support at the beginning until I do a few of those myself. And I feel I can be more independent and then maybe transfer it to others, then I can feel that I know what I'm doing.
Okay.
But it's a very good start. Thank you.
Good.
Really good start.
I feel that I need to go to the basics again, but it's an important focus, but we need training. I need training.
No, it is. It's
One thing that I
practice.
felt was lacking maybe is if you could show us papers that are not good, like examples of like if we could analyze something and we could see some stuff that it's in a very good paper, it was published, but this and this and this is not. Like in a practice, it sometimes sheds a light on how you would want things to be.
That's a good
I
point.
think in the time schedule that we had, it was perfect.
Yeah. No, and with the medical,
this should be a course by itself with just coming and analyzing one after the others, all kinds of papers and with examples of bad examples.
Yeah. With the medical students, when we do teach EBM, they actually have 12 hours in their course, and we do bring bad examples, but because time here is so limited,
with the time limit, that was great fun.
Good. Okay, well, I have put my details on the board. Feel free to contact me. I'm at the faculty, so I'm close by if you need any help with anything, or if I can help in any way. You have my email and my number.
Thank you very much.
Thanks a lot.
So as I said, I think there is, if I have review was maybe 100 student review alone, I could understand what I get today here.
Good.
So it was excellent. Thank you very much.
You're welcome. I'm glad to hear that.
Very good.
Good.
Now we need to find the time to do it regularly, because if you don't do it, then it stays
But
like
now
that.
when you're doing your literature review,
Right.
do it for each article.
Yeah, we're gonna really use it.
So I'm gonna send you the PDF of this presentation, plus the two tools,
Yeah, that's
the
great.
tools, and the recording will come in a few days.
So you do that on each paper you cite in your literature review? Everything, like I have 30 papers, each one of them.
For practicing.
No, I'm asking like when you write the paper.
No, but
No, like it gets to a point where you know what to look for and you know what's good and what's less good, and you can't, like, to be realistic, you can't sit and
Because
do,
someone is editing it and
Yeah.
someone is reviewing it and someone publishes it and others cite it and others.
Yeah.
try
if you
to-
do a systematic literature review, then you must do it.
Yeah.
Yes, but if I
But-
write now, okay,
On what year do they study? This
it's
course?
the end of the first year.
It's too early.
but you know, they come to
So
second
it's
year and they
not-
don't know likelihood ratio what it is. We teach them that. Positive predictive value, negative predictive, and they don't
Yeah.
understand them. I think it's too early.
I agree, but we only have them for 2 years in the faculty, because
It
it's,
should be at the end
they're
of
after,
second
it should be, it's after their tour.
or clinical years. It should be in the clinical
Before
years.
departments. Because in each
Mm.
journal club, we take a publication and
Mhm.
tear it apart.
Yeah, but then
With these
you
tools.
lose control, because there aren't one professionals,
צריך לא קיבלו אותי שם.
Okay.
then maybe it's a better idea if they had supplements